Top Bed Talk.
So our first speaker is Dr. Chloe Grimmett. She is a National Institute of Health Research Postdoctoral Research Fellow and Senior Research Fellow for the Macmillan Survivorship Research Group at the University of Southampton. Chloe is a behavioral scientist with particular interest in the role of physical activity in cancer recovery and the development of interventions to support long-term engagement in physical activity. Chloe is the behavioral science lead for Wessex-Fit-for Surgery, or WesFit trial described yesterday, is a member of the National Cancer Research Institute Clinical Studies Lifestyle and Behavior Change Group, as well as the NIHR Cancer and Nutrition Collaborative. Please welcome Dr. Grimmett.
Okay, thank you very much. And I'm also not Rob Copeland, who is in your bit, but I'm guessing you realise that he couldn't come today. So thank you for having me. I'm going to talk about behavioural science and psychological support within prehab. And first off, I was at the Poets conference a couple of years ago, and this was hardly mentioned. And the last couple of days, there's been lots of talk about patient empowerment and behaviour change techniques. So from my point of view, it's fantastic to see. And I'm just going to give you a broad overview of those two constructs. So, as I'm sure you're all aware, the historical focus really in prehab has been very much around exercise and around mechanisms of actions and physiological outcomes. But there's emergent interest in the role of psychological support, psychosocial outcomes, and also behaviour change. And importantly, and I think you probably would have got the message about this now over the last couple of days, they're not the same thing. And I'm going to talk about them in two halves today. So when we think about multimodal prehabilitation, we tend to think about exercise, nutrition, and psychological support. And then I would argue that running across all of that is behavioural science. And I'm going to start off by thinking about psychological support. So none of you will be surprised to hear that a cancer diagnosis often results in patients feeling a lot of fear, a lot of anxiety, and a lot of distress. And we heard that from our patients yesterday. But you might not be so aware of the data that looks at the impact of those psychological constructs on physiological outcomes, as well as quality of life, both in short and long term. And a paper Denny and I published this year looked at a scoping overview of that work. And in the event you can't read that, we concluded that preoperative anxiety, depression, and low self-efficacy, that's confidence to manage, is consistently associated with physiological outcomes and health-related quality of life in the long and short term. So just looking at that in a little bit more detail, there's consistent evidence, and most of this, I should say, is from the cancer literature, because that's my background, that anxiety around the time of diagnosis is predictive of post-operative pain. Depression around the time of diagnosis increases someone's risk of chronic pain, so for years after surgery. And psychological factors also impact on real physiological things like wound healing and also functional recovery. And we've heard quite a lot about confidence this morning and yesterday. And these two papers talk about the role of low confidence or self-efficacy to self-manage, and also the role of depression in predicting longer-term outcomes. So this work comes from something called the CREW study, which was run by the MSRG group, the Macmillan Survivorship Research Group in Southampton, and we followed a cohort of around 1,000 colorectal cancer patients. They were given questionnaires around the time of diagnosis and then at regular intervals for years afterwards. And we wanted to see what factors predicted who had a better or worse recovery in terms of these psychological issues. And the patients who reported the lowest confidence to manage what was about to happen and high levels of depression had worse trajectories of quality of life, so they're doing worse at 2 years. And that was irrespective of the disease characteristics or the treatment they had. So it didn't matter if they had a stoma, it didn't matter if they had just surgery and not chemo. If they had low confidence to manage, they really struggled in the 2 years afterwards. And that level of self-efficacy doesn't seem to change over time, so that supports the importance of intervening early. So The obvious next question is then, does modifying these preoperative psychological states improve patient outcomes? Well, there's been a couple of reviews in the area, but the evidence base is still actually very small, and I would say possibly, if I was feeling a little braver, I'd say probably. I think it's likely that the more evidence we get, the more likely we are to see positive impacts of these things. But there's a huge number of limitations to the evidence, which is mentioned in the guidelines or the guidance, that was launched last night. So there's very few randomised control trials that look at psychological interventions in prehab. So when Macmillan did the evidence synthesis for the guidance that came out yesterday, there were only 18 RCTs in the 182 pieces of evidence that we retrieved. There's a huge range of outcome measures used, so it's really hard to synthesise the evidence to see what impact these interventions are having. They were often very poorly described, so it was really difficult to know what people did. They certainly weren't replicable, so it's very hard to know, okay, so someone did something and it worked, but we don't know what that was. And there was also a lack of stratification, so it wasn't necessarily the patients in most need that were receiving these sort of psychological support interventions. And most of the interventions that we're talking about here are things like relaxation techniques and imagery and that kind of thing. So ultimately we need more work in the area. So moving on then to behavioural science. So as I said, behavioural science cuts across all parts of prehabilitation, but for the sake of time I'm going to use exercise as an example. So when I first met Sandy Jack and the team at Southampton, I was absolutely amazed by their adherence rates to their prescribed exercise programs. They're incredible, around 90% consistently. And I was really interested to hear more about what the team were doing. How were they getting patients to engage so well at such a difficult time? And I spoke to the team, and it became apparent that they'd embedded a lot of behaviour change techniques, which is the terminology us behavioural scientists use. And I'm sure Sandy won't mind me saying it was kind of by accident. But these are some of the things that they talked about. So the sessions were supervised. So the patients had really clear instructions about what they were expected to do in a very safe environment. There was action planning, and what we mean by that is when, where and how are people going to do this behaviour. So they had appointments, they knew what was expected of them, and really importantly, they had a backup plan if they couldn't come to an appointment. They knew there was flexibility in the system. If they were unwell, if they had a clash with a medical appointment or another engagement, they were able to change it. And the patients really felt a sense of increased confidence over the time working with the fantastic team, including people like Sam, who you heard from yesterday, who were constantly giving regular positive reinforcement and encouragement, telling the patients, look, you're doing really well, and patients could see their improvements, which really increased their confidence. And this was this setting of graded tasks where there was this progressive exercise program, and there was a huge amount of social support, both from the team and also sometimes using buddies to be exercising with. Then they tried to encourage patients to exercise at home, and the adherence rate dropped from around 90% to less than 10, I think was about right. And it's because exercising independently is much more complicated for people, especially when they're having a difficult time through cancer treatment and surgery. And patients really need tools to help them manage this behaviour change. And we've heard a lot about this idea about people are motivated, but they don't have the confidence and they don't know how or what to do. And so if we're going to encourage patients to exercise independently, we need to build their self-efficacy or their confidence. There's a huge amount of evidence that those who are the most confident go on to be more regular exercisers. They need an environment and resources that enable them to do that. What's their physical environment like? What caring responsibilities do they have, for example? And they need support with action planning. They need to be asked how, when, where are you going to do this? What might get in the way and how might you overcome that? And they need ultimately to be engaged in the process and feel as though they own it. They need to come up with these plans so that they have ownership and autonomy and confidence over what they're doing. So we're trying to build this into the WesFit study. I won't go into detail about this because hopefully you heard about that from Sandy. This is a 4-armed RCT. 2 arms of the trial are given exercise intervention, and it's supervised in community gyms by personal trainers. And these personal trainers get training in something called Healthy Conversations, which is part of the Making Every Contact Count initiative, which people have been talking about over the last couple of days. And it really teaches the personal trainers to use these open discovery questions to empower the patients to come up with their own plans. So while they're being supported to exercise to make sure they get the dose of exercise that the team want for the sake of the RCT, they're asked to think about what might they do after surgery. What are their priorities? How might they go about exercising after surgery? Who might they do it with? What have they liked doing in the past? And who might they be able to do it with? And the shift very much is, rather than advising and talking, it's about asking and listening. And that's the real shift. And as Mo mentioned yesterday, she talked about a focus group. I don't know if you remember. And that was a focus group that we ran with patients that have been involved in previous trials at Southampton to ask them what worked well and what they might like. And she said there was a unanimous call for continued support. So we've built that into WesFit, and the personal trainers will be calling the patients at 12 weeks post-operatively to talk to them about how they're doing, to see if they've got any concerns about exercise, and reassure them that they're safe to go on and exercise in the future, and support them to make plans to do that. And they're speaking to them at 12 weeks and at 6 months in the hope that we will see that continued behaviour change. And it's very early days, but we're seeing positive signs that this might be having an impact. So as part of the WesFit trial, we've conducted a preliminary process evaluation. So we hit the ground running. We wanted to speak to patients to see how things were and see if any changes needed to be made to the programme. And I had a number of conversations with people involved, and there was lots of talk about people buying exercise equipment, getting their bikes out of the shed. So this gentleman used to cycle, had a bike in the shed that was getting a bit rusty, hadn't been out of the shed for 2 or 3 years, and the conversations he had with the personal trainer really prompted him to get the bike out and use it again. And I spoke to him about 14 weeks post-operatively, and he was riding either outside on his bike or inside on a stationary bike that he'd got almost every day, which was just fantastic to see, and hopefully we'll see more of that in the future. I think really importantly, and we've kind of heard about it from others, is support for behaviour change really is everybody's business. And if patients get a consistent message about exercise being medicine, this is part of your care plan, this is something you should be doing, arguably patients are more likely to adhere to that. And there's been a number of pieces of work, particularly carried out by a team at University College who I used to work with, that show that patients really want this advice, and most of them actually see it as a doctor's duty to give it to them, which is really interesting because there's a lot of concern about, well, are people going to feel guilty? Are they going to feel blame for their cancer because they haven't been exercising in the past? And there really seems to be very little evidence that that's the case, and patients really want this advice. As I say, if it's discussed in the context of their treatment plan, it gives credibility to the importance of these behaviours. And if we have this consistent message from staff, it's going to be really impactful. So one of the things you can think about is getting training through the Making Every Contact Count initiative, which is usually 3 through NHS Trust, and we heard about another opportunity as well earlier this morning. So you've seen this triangle too many times now, but ultimately this kind of stratified approach sings to psychological support and also to behavioural support as well. So some people, who have been regular exercisers all their life will need very little, whereas others who are potentially quite frail, never identified as an exerciser, if you like, it's not their thing, might need a little bit more encouragement, so that importance of stratified support. So just to finish on the key messages then, psychological factors have a real impact on surgical outcomes. They're really important. We need to address them in a stratified way, as we've heard before. Psychological interventions might improve outcomes, but we need more evidence to be sure of that. Behaviour change is everyone's business, and it's important throughout the prehab multimodal approaches. And I think it presents a really important opportunity for long-term change. The patients we talk about have, the ones involved in the prehab trials at Southampton, have seen firsthand the power that exercise can have in terms of really helping them through the rigours of surgery. And if they have that experience, they can translate that into longer-term change, is the hope. And finally, thank you to Sandy, who, if I hadn't met, I wouldn't be in this exciting world of prehab. To the WesFit team, who are brilliant, even if they do buy you Jaeger bombs at 12 o'clock the night before your presentation. And our fabulous, I didn't drink it, I promise, our fabulous patients, who you've heard from already, but they really are an inspiration, so thanks to them.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.